am Dr. Tami Prince, and you are watching Health Tips with the Nation's Bedside Doctor on Clark TV Network, where we believe in the future. On this show, we have real talk on real issues that affects our communities every single day. Thank you so much for tuning in and trying to unwind with me on a Thursday night. I am so thankful we made it to Thursday. I don't know about you, but I really need to unwind. So I am ready to do it with you all. Now, it's March, and it is still National Women's Month. So, of course, I am highlighting a new trailblazer that's in the medical field who also just happens to be a woman. Her name is Dr. Eliza Ann Greer, and she was an emancipated slave born in Mecklenburg County, North Carolina in 1864. Dr. Greer moved to Nashville, Tennessee with her initial dream to study teaching at Fisk University. While enrolled at Fisk in 1884, she had financial issues, and every other year she had to alternate going to school and working. And she actually picked cotton in between the time when she had to go to school and working, just to make sure that she had enough money to get her tuition fees paid. So it took her about 7 years to do that. She actually graduated in 1891 from Fisk University. But during that time, even though she initially went to be a teacher, she actually felt that she would be of more benefit to her race by getting a medical education. So Dr. Greer wrote to the Women's Medical College of Pennsylvania in December of 1890, before she graduated from Fisk, to inquire about the cost of medical school there and whether or not there was any work she could do that would not interfere with her studies. Quoted Dr. Greer, "I have no money and no source from which to get it," she said, "only as I work for every dollar." She asked the dean of the medical college whether, quote unquote, any possible way might be provided for an emancipated slave to receive any help into so lofty a profession. Dr. Greer was also able to call on a number of distinguished supporters to enlist financial aid, one of those supporters being A.W. Whitaker, who was Bishop of the Episcopal Diocese of Pennsylvania, who wrote her a recommendation to support her application for medical school. She was admitted, and once again, just as she did at Fisk, she alternated working with paying and going to school. She completed her medical studies in 1897, earning the degree of medical doctor. And according to a notice in the North America Medical Review in 1898, when Dr. Greer applied for a license to practice medicine in Fulton County, Georgia, right here in Atlanta, she became the first African American woman admitted to practice in the state. She's quoted as saying, "When I saw colored women doing all the work in the cases of what at that time we called accouchement, that's childbirth, and all of the fees were going to some white doctor who merely looked on, I asked myself, why should I not get the fee myself? For this purpose, I have qualified. I went to Philadelphia, I studied medicine hard, procured my degree, and have come back to Atlanta, where I have lived all of my life to practice my profession. Some of the best white doctors in the city have welcomed me and say that they will give me a chance in the profession. That's all I ask." Now, tragically, Dr. Greer was not able to practice medicine very long. She fell ill in about 1901, and therefore she was unable to keep her medical practice open. She wrote to Susan B. Anthony, who at that time was leader of the National American Women's Suffrage Association, to ask for help. Now, while Susan B. Anthony did not have the financial means to assist Dr. Greer, she did write a letter on behalf to Dr. Greer's medical college, Women's Medical College of Pennsylvania. And throughout her struggle to qualify and practice medicine, Dr. Greer never gave up. She eventually had to move to Albany, Georgia, where her brother, who was also a physician, Dr. Richard Edgar Greer, lived. Dr. Greer died in 1902, just about 5 years after she began practicing medicine. When she died, she had achieved a remarkable feat. Despite being an emancipated slave with little money or education, she went to a leading medical school and became the first African American woman licensed to practice medicine in Georgia. Dr. Greer, I salute you. Now, as you also know, I like to give you the most up-to-date information in the medical field. And actually today, that's going to be about foods that we should not be eating while we're on medicines. Now, a lot of us are watching our diets really good, maybe. And we also may be taking medicines, but what we don't realize is sometimes those medicines can interact actually with the foods that we are eating. And so I want to take the time right now, since there was an article that was just published in MD Links by John Murphy actually yesterday. And it's just a reminder that what we put into our bodies, we need to know about. You know, we can't just aimlessly be eating things and taking medicines and we don't know what they do for us. So one of the biggest interactions that happens is grapefruits. Now, grapefruits may taste good, but sometimes they don't go well with medicines. And one of those medicines happens to be statins. Now, we use statins for high cholesterol. And while they control the statins controls the high cholesterol really well. Sometimes the grapefruit can actually potentiate those effects from the statins, good and bad. So what John Murphy actually quoted in his article, there was a study that was done and published in the American Journal of Medicine, and it showed that when drinking a glass of grapefruit with either 40 milligrams of simvastatin or lovastatin, it increased the effective dose of the statin by 3.6 fold. So that's a lot. And even when the grapefruit was consumed 12 hours after taking the drug, there was still a 1.9 fold increase. So, you know, that's a lot. And like I said, it has good and bad effects. One of the biggest effects that the statins has is something called rhabdomyolysis, where it's a rapid breakdown of muscle in the body, and that could potentially have a fatal effect when that's done, especially if the rhabdomyolysis is happening in the heart. So it's not something that you want to play around with. The medicines should come with a warning on them, and your doctor should also be talking to you about which medicines you need to avoid while you're on the statins. So make sure you do not eat grapefruit on statins, please. Next one, and this is maybe a not so well known fact, bananas and ACE inhibitors. So a lot of people are on ACE inhibitors because of blood pressure issues, and actually you can also treat them for heart failure as well with the ACE inhibitors. Now, what the ACE inhibitors do is they increase the amount of potassium in the body, and it disrupts the potassium balance. So when that happens, it can be critical because too much potassium can interfere with the electrical signaling in the heart, and it can cause irregular heartbeats and palpitations. So when you eat foods that have high potassium, such as bananas, then your effect can be potentiated. Now, other foods that also have potassium, which you may not know about, are beets, avocados, oranges, orange juice, potatoes, spinach, tomatoes, so everything that we like, basically. So once again, it's your whole diet. Be careful with bananas or anything that's got high potassium and you're on the ACE inhibitors. Another interaction is warfarin and kale. So we use warfarin as a blood thinner, especially when people have had blood clots before, when you've had strokes, heart attacks, things like that, where you need to have your blood thin. Well, kale also has that interaction where it actually inhibits what warfarin's job is. Warfarin's job is to decrease the activity of vitamin K. And what vitamin K does is it decreases your chance for having blood clots, so it basically thins your blood. But what the kale or foods that have high vitamin K in it, it actually decreases those effects from warfarin. So you want to stay away from your green leafy vegetables, kale, spinach, or if you don't want to stay away from it, at least have it in small amounts and eat them regularly. Once again, make sure while you're on these blood thinners, you're having your lab work done as you're supposed to with your physician, so that you don't have any issues with that. And then the last interaction with, actually it's not the last one, it's black licorice and digoxin. So we use digoxin, or DIG as we call it in the medical field, to treat heart failure and atrial fibrillation. And so what it does is it slows down the flow of the sodium and the potassium in and out of the heart cells. And what that also then does is it strengthens your heart. Well, what DIG and black licorice do is they kind of butt heads. So the black licorice actually elevates sodium levels and reduces potassium levels. So now if you're eating black licorice and you're on DIG, that can spell trouble for you. So once again, try not to eat black licorice, or once again, talk to your physician. Okay, that's the main thing here, is that your physician and you should be having a conversation to guide you properly on what your diet should be like and what your medications should be, and also how you're taking them. So you can't take any of that lightly. Now the final drug interaction, cheese and MAOs. Okay, so we use the MAOs, or the monoamine oxidase inhibitors, to treat depression that's resistant to other medicines. But what they do is it blocks an enzyme that breaks down the excess amounts of tyramine in the body, and thus relieves the depression. Well, eating foods that have tyramine, such as your cheeses, your aged cheddar, your camembert, your Swiss, your Parmesan, your blue, all the great cheeses, they have this high amount of tyramine. And so when you're using these medicines, you have to be careful, because once again, it'll butt heads. So, just know what you're putting into your body. That's the most important thing. Know what you're putting into your body, and having that conversation, keeping the lines of communication open with your physician. That is the most important thing that you can do with all these new diets and having restrictions here with this food group and not having restrictions here with that food group. It gets kind of tricky. So just everything in moderation, and keeping the lines of communication open is the biggest advice that I can give about that. So when we come back, I'm going to introduce all three of these people that are here with me. They are knowledgeable in the topic that we're going to be discussing tonight, which is MS, multiple sclerosis. So you stay tuned. We'll be back shortly.
My name is Cheryl Fife-Marisich, and I'm an assistant professor here at the University of Pittsburgh. And my lab is really interested in understanding the mechanisms of myelin repair, and that's what we're really interested in terms of MS research. We're really trying to understand the different molecules and signaling pathways that are important for the development of those cells called oligodendrocytes, the cells that make that fatty coating called myelin that degrades in patients with MS. We're interested in trying to understand what pushes those cells to start making new myelin. And then we're also interested in what allows those cells to keep making myelin, so that that myelin sheath is of good quality or is of an appropriate thickness. And so over the last decade, a lot of new clinical trials have been started, and a lot of information has come out, and we know a whole lot more now about the process of myelin repair. And we know that at least in healthy people and in patients with MS, at least early in the disease, myelin repair does happen. And so what we need to do is to try and find strategies to restore that myelin repair in patients with MS. You know, MS is a disease really that's all around us. My next door neighbor has MS. One of my colleagues just down the hall has MS and is in a wheelchair. And so having those patients around me all the time is really very motivating, so that I can remember that, you know, these things that seem so small right now that I do in the lab, I really hope that at some point that they will be translated and they will be useful to patients who have MS. So getting funding through the MS Society early in my career was really so critical, and I can't overstate how important that was. I was able to meet other MS researchers and form collaborations that I have continued to benefit from even all the way until today. Because I think the MS Society really provides a sense of community, and it really enables you as a young researcher to meet other people who have the same goal. I mean, we all really want to make people with MS better.
People join Walk MS to raise awareness and funds that change the world for everyone affected by multiple sclerosis. MS attacks the brain and spinal cord. It's the most common neurological disease leading to disability in young adults. Walk MS brings communities together, creating teams with friends, loved ones, and coworkers to rally around those we care about and end MS forever. Join us. Together we are stronger. Walk MS fundraising accelerates research breakthroughs and life-changing breakthroughs. It will take all of our passion, determination, and fundraising to end MS forever. Together, we can change the world for people with MS. Join us. Register today. Start a team.
We are back. Thank you so much for staying tuned to discuss our topic tonight, which is multiple sclerosis. So March is designated as Multiple Sclerosis Awareness Month. And tonight, to help me bring awareness and dissect this condition, I have three guests with me. So I'm going to start off on my right-hand side with Dr. Guy Buckle, who joined the Andrew C. Carlos MS Institute at Shepherd Center as the Director of Neuroimaging Research in 2014. Dr. Buckle comes to Shepherd Center following 20 years or nearly 20 years, I guess, at Brigham Women's Hospital in Boston. Most recently, he was the Director of Clinical Care at Partners Multiple Sclerosis Center at Brigham and Women's Hospital. He also served as Assistant Professor of Neurology at Harvard Medical School. He was drawn to Shepherd Center's MS Institute for the chance to work in a smaller environment and to expand the center's neuroimaging program. A native of Washington, D.C. area, Dr. Buckle graduated from Tufts University with a bachelor's degree in music and master's degree in music theory and composition. He received his medical degree and master's in public health from Tufts University School of Medicine and completed his residency in neurology and fellowship in neuroimmunology and MS at Brigham and Women's Hospital and Harvard Medical School with funding from the National MS Society and the National Institutes of Health. Dr. Buckle began working in multiple sclerosis basic immunology research during medical school, but it was not until after he completed his neurology residency that he realized his passion for treating individuals with MS and decided to focus on patient care, clinical trials, and neuroimaging research. Dr. Buckle lives with his wife, who is originally from North Carolina, right here in Atlanta, and they have two spoiled cats. Beyond practicing medicine, he has a passion for music. Welcome, Dr. Buckle.
Thank you
I
very
love
much.
that about you. You know what a lot of people think when we go to medical school is that, oh, you got to major in some kind of science or math and then you get to medical school. But nowadays, a lot of physicians have diverse backgrounds.
Absolutely.
And so Dr. Buckle is one of those. And I love music. I probably should have been a music person, but I wasn't. So in my next life.
There's still time.
There's still time. That's right. That's right. That's right. Now, sitting next to me, in between Dr. Buckle, is Miss Faye Gibson of Alpharetta, Georgia. Faye is 43 years old and is a payroll specialist at a local software company. She was diagnosed with remitting MS in 2008. Despite her MS, Faye participates in Challenge Walk MS, Cape Cod, which is a 3-day, 50-mile walk on Cape Cod in Massachusetts that raises money for the National MS Society. Her team is named BFFs Against MS because she walks with all of her best friends forever, and they walk with and support her. Faye says, MS has taken away my hearing, vision, sense of smell, and my ability to walk at different times over the last 10 years, but it has given me so much more. I use my voice to help others diagnosed with MS by connecting them to neurologists who can help. I have connected them to the National MS Society so they have access to groups and programs that can help them, especially when they are newly diagnosed. Welcome, Faye. Thank you so much for sharing your story, because it's so important. As physicians, you know, we can get into, the diagnosis and the treatment, but this is a person that we're treating.
Yeah.
And
Absolutely.
we sometimes don't know all the ins and outs after we diagnose and while we're treating patients. And so I'm glad that you're here to be able to give that patient
Glad to be here. Thank you.
standpoint.
Yeah.
I applaud you for that.
Thank you.
And finally, I have somebody who is from my hometown, Cleveland, Ohio. I have Miss Ellen Perry, who is the Associate Vice President for the National MS Society in Development here in Atlanta. So Ellen has been with the Society for 2 years, raising awareness and funds for MS research and programs and services for people living with MS. She has more than 20 years of experience in development work in higher education and other disease-oriented non-for-profits. Prior to her development work, she was in the professional sports industry. So she was in corporate sales for the NBA, Cleveland Cavaliers, and professional tennis management. Thank you so much, hometown girl.
Thank you. Exactly.
How you enjoying this weather, girl? Much different than from in Cleveland when they've been
absolutely.
getting hit with the snow. So thank you all so much for coming and taking time out of your busy schedules to join me to discuss this important topic. So before we actually jump in, I want to actually give some statistics, if that's okay. So when I was in medical school, we always were told that MS is one of those conditions that is what we call the great mimicker. And there's a reason why it is called that. So we'll discuss that a little bit later. But did you know that multiple sclerosis actually means many scars? So when you have MS, there are lesions of areas of inflammation all throughout the nerves and the brain and the spinal cord. And when the inflammation gets better, or what we call remits, those areas of damage may either be partially repaired or they can form a permanent scar. So if this is happening over a period of time, that's why the name is what it is, many scars. Approximately 400,000 individuals have been diagnosed with MS in the U.S. and as many as 2.5 million worldwide. So that's a pretty good number. And estimated 10,000 new cases are diagnosed in the U.S. every year. Most people with MS experience their first symptoms and are diagnosed between the ages of 15 to 50, so a wide range, although it can be diagnosed before the age of 15 or even after the age of 50. Now, on average, with the relapsing forms of MS, women are 3 times more likely than men to develop this disorder. With the primary progressive form, genders are more equally divided. And also, it seems to appear that people who live further from the equator, either the extremes, the far north or the far south, have a higher risk of developing MS than the people that live near the equator or have a hotter area. So we'll talk about that a little bit more. There are different types of MS, and we'll break that down. I did say in phase bio that she has the relapsing remitting MS, and we'll talk about what that is. So now, Dr. Buckle, can you explain more in depth what MS is?
So everything you described, the question for us is, the big question is what causes it, and we still don't know. Most people consider it to be an autoimmune disease, which means that the immune system is reacting against a normal tissue in your body. In this case, some component of the brain, the spinal cord, the optic nerve. Those are the three parts of the central nervous system. And it's recognizing it as something foreign, a pathogen, an infection or a malignant cell or something like that, and it triggers an inflammatory reaction, which then causes a scar, as you say, when that inflammation goes away. But then it typically comes back somewhere else, and it causes a new symptom depending where in the central nervous system it comes back. So that's why there's so many different symptoms that you see in MS. That's why we call it one of the great mimickers in neurology, because it can look like so many different things, especially in the variety of symptoms that it produces.
On average, because it is the great mimicker, how long do you think people go without being diagnosed?
So that's a great question. It depends, of course, where you live, for one thing. So in the United States, Canada, in Europe, I'd say people generally get diagnosed within the first couple of years of the onset of symptoms, sometimes much sooner. And a lot of that has to do with access not only to healthcare, but especially with access to MRI scans. So now that MRI scans have become so common, at least in the industrialized nations and everything, we're almost seeing the opposite effect. Sometimes MS is being discovered incidentally on an MRI scan, even if the patients had absolutely no symptoms at all. And those are patients that we're not sure whether should be on treatment or not. We typically follow them to see if they come down with MS later. But it's also not uncommon in some rural areas and so forth to see people go many years with all the symptoms of MS. It's not recognized for whatever reason. They don't have a lot of coordinated health care. They're going to emergency rooms. They're being told they have stroke or migraine or something like this. In fact, they end up having MS, and when you look back over it years later, you can figure out they had MS for a long time and just didn't know it. So it can go either way.
Faye, talk about your experience with MS and what led up to your diagnosis.
Okay. I could remember back in my late 20s, I was always tired, and I thought I was just lazy. And I think that's one of the things that people go through. They're just like, well, this is normal. I'm just, need more sleep. But in fact, it's fatigue, which is a little different than just being tired. But I was in New York. It was really cold, and that's one of the triggers sometimes to the relapsing. And I felt like a shock go through the left side of my body. I actually looked around because I was like, did anyone else feel that? And I thought I was having a heart attack initially. But I came back, saw my general doctor, who recommended an MRI, which she was actually really good in doing that, because a lot of doctors, they don't. And she called me a couple weeks later and said, I see something on your MRI. There's a spot there, and I want you to see a neurologist.
What was her initial thought process? Did she talk about why she wanted to get the MRI?
Just my symptoms. My left side went numb. I couldn't feel anything, but it started coming back, and I think that's what triggered in her mind that it may be that I'm having a relapse. She didn't say that to me because she's not a neurologist, so she wanted to dig deeper. She was very thorough. Like, she tested me for everything else and kind of ruled out a lot of different things, and then she recommended that I see a neurologist after she got my my MRI results back, which I did, and I was misdiagnosed like most patients. And it's unfortunate because a lot of people think it's just in their mind. Once a doctor says, it's a cold or you have a migraine, they just kind of leave it at that. You do have a right to a second opinion.
And a third.
And a third.
if you need to.
So I saw a different doctor, a pain specialist, because I did have some pain in my side, but again, it was getting better. And he said, "Listen, I think you should see a neurologist." And I said, "Well, I already saw one." He's like, "We'll see another one," and I did. And within minutes of seeing this new neurologist, just in me walking and explaining to him how I've been feeling, he's like, "You have MS." He didn't even look at my scans, and he did another MRI just for his purposes, and did a spinal tap. Because he said, once you've been misdiagnosed, I want to make sure that, we know exactly what it is. And that actually told him for sure that I had it.
Was there a difference between the MRI that he did and the one that had previously been done?
So there were a few months that had went by between me doing the first scan and just being misdiagnosed. And so initially I had one spot on my brain and one on my spine. And then I had 3 spots on my brain at that time. So, he's like, and it's getting worse. So we need to start your treatment as soon as possible. So
What were you initially misdiagnosed with?
my doctor told me I had a cold virus. And
And that was after the MRI showed you had a lesion?
yes, he did. He actually said, and I'm from the Caribbean, I'm from St. Vincent. He said, you're from a hot climate, so, I don't think that you have this. But I left when I was 10 years old, and I lived in New York. And so, my new neurologist was telling me, he was like, you weren't there long enough for whatever needs to be built in your brain to have that, So he's like, you have it. And I was shocked. I really was. But relieved also because you're walking around and you're not sure what's going on with you. And just to have someone tell you this is exactly what it is and this is how we can treat it, I was definitely relieved to know what was wrong.
And the fact it can be treated.
And it can be treated. And he did say that to me. He's like, this is not, like you said, a death sentence. You can control this disease, and you will. He's like, it's a mental thing. And if you get your mental right, you can fight this disease. And so that's what I've been doing for the last 11 years.
Dr. Buckle, why do people think that this is a death sentence?
Well, we've only had effective treatments for MS, or at least FDA-approved treatments, for about 20 years now. So in the old days, the numbers were about 85% of people started with relapsing remitting MS, but then the vast majority of those, probably 80% of those, would go on to what's called secondary progressive MS, which means that you're not having, this is generally when you get into your 40s, 50s, let's say you're diagnosed in your 20s or 30s, it might take 5 years, it might take 10, it might take 20 years, but before there were any effective treatments, almost everyone went into this secondary progressive phase where the disease continued to get worse slowly. Weakness got worse, cognitive problems got worse, everything got slowly, steadily worse, even when there were no relapses and no more activity on the MRI scan. And that's really when the disability starts to accumulate. And so the whole thrust of the field now is to get people diagnosed as early as possible when it's in the relapsing remitting stage and get them on treatments, because all the treatments are approved for relapsing remitting MS. With one exception, there's one treatment for primary progressive MS, which is a different disease course. But there are no effective treatments for the secondary progressive MS. So we have to get people on treatment as early as possible once we know they have MS, or they've had at least one attack of MS and they have an abnormal MRI, because all the studies have shown that that's the only way to prevent people from getting into this progressive disability phase.
Now, there are types of MS. How many types are there?
We used to say 4, now it's really more like 3. So the relapsing remitting MS is by far the most common. That's about 85%.
That's the one that Faye has.
Right, and then there's one primary progressive MS, has no relapses by definition. It just gets slowly, steadily worse from the outset, and that's about 10%. And there was an older description called progressive relapsing. We've kind of abandoned that because nobody could really agree on what
that is.
And then there's a few percentage there of unusual presentations and so forth that don't quite fit either one. But the secondary progressive MS by definition starts as relapsing remitting. So
Okay, and then it progresses.
And then progresses.
And what makes it progress?
That's the $1 million
Yeah.
question. If we knew that, we could design effective treatment.
Yes, and you and I can go home and
Exactly.
not work anymore.
And that's where we need to put all our resources now, because we've got a pretty good handle on the relapsing remitting course, and we've got good disease-modifying therapies, but we don't for progressive MS.
Ellen, are there any studies on the horizon that are looking at that you are aware of?
Yes, there's a lot of studies taking place, a lot of clinical trials and research that we are funding globally, not just in the U.S., but we do fund all over the world, basically without borders, unless you are on the no-fly zone. We're not going to enter there.
Right, yeah, don't
But,
enter there.
no, because too, people with MS, they don't care where the cure comes from, as long as we have it. So we fund the most promising research out there, and that is what we do and what we strive for.
And where do you get your funding from?
We get a lot of our funding from, private individuals, donors, investors, companies, but also a lot through our fundraising efforts. And that is, some of our events that take place across the country where you can get involved in. So you are welcome to join us at our Walk MS, our Bike MS, Challenge Walk, Muck Fest, and all of our various fundraising events that take place across the country. So there's plenty in your area. You can go to our website, nationalmssociety.org, find your state, and we are there to welcome you and get you involved in our movement.
When are the walks?
Currently, the spring is our highest walk season. So yes, you can, again, go to our website, find a walk in your area, sign up for yourself, or bring a friend, a colleague, family, and join us and support us in our community.
Absolutely. Now, what are the symptoms? Faye mentioned some of her symptoms, but what are some other symptoms?
So common symptoms of a relapse would be the one she was talking about. That's generally a lesion in the spinal cord. Can cause numbness, tingling, weakness, and electrical sensation when you bend your neck. That's a very common presentation. Another one would be optic neuritis, which is loss of vision. Usually it's in one eye. Rarely it's in both eyes. Usually one eye, and that's often painful, especially when you move your eyes.
Yes.
You probably experienced that one.
Yes.
Another one is in the brainstem. MS can cause double vision, vertigo, feeling of being off balance, that sort of thing. Weakness, numbness. But it's important to realize that these symptoms don't come and go, within minutes or hours or something. They come on over the course typically of days, and they persist. So we don't really even define something as a relapse unless it lasts at least a day or two, and it's usually a new symptom. But if in doubt, you have to call your doctor, your neurologist, whoever you're seeing, and be evaluated.
And in general, how long do relapses last? Obviously, it's person dependent, but
Right. Usually on the order of a few weeks, sometimes a few months, and unfortunately there are some relapses that you don't recover from. So that's what causes people to get into this progressive disability phase, is they don't have complete recovery from every relapse. Early on, when people are young and have more sort of a reparative capacity in their nervous systems, they can recover fully. But as the years go on and the relapses accumulate, the disability persists. So
Faye, how long does it take for you normally to recover?
So for my optic neuritis, it took probably like 3 months. So I did, and it's a treatment. I actually was treated on the island of St. Vincent, which my doctor was amazing, just getting that to me. They did a Solumedrol kind of treatment for I think 5 days, and I had to keep checking my eye, just do an eye test, and then I think maybe 3.5 months later, my vision came back.
Okay.
And there was a time when I wasn't able to walk, and that lasted for about a week. There was another medication that was administered, which they've used in babies that are still developing in the mom. Forgot the name of it, but it was amazing. To not be able to walk was like my biggest fear. And when I got up and, falling down, I fell down a flight of stairs before because there was numbness. And just having that medication available to be treated, and then months later I was able to walk.
Would that have been betamethasone?
no, probably ACTH,
And-
Acthar.
Yeah, it was
okay.
Acthar.
Right.
That's exactly what
Okay.
it was.
So the mainstay
amazing.
of treatment for relapses is some form of steroid or something like
Yeah.
That's why I asked about betamethasone, because
Right.
that's what we would,
Acthar was it? Yeah, I've only taken it once, but it was really good.
Okay. Now, does race play a role in diagnosis?
Yes, absolutely. So MS is much more common in people of Northern European ancestry, particularly Caucasians. But unfortunately, when it does affect African Americans in particular, they tend to have a worse course of MS, especially men. African American men are in one of the highest risk categories for progressive MS.
Why do you think?
Don't know. So there's a genetic component there, of course. So there's one gene that's been identified consistently to be associated with your risk of developing MS, and that's, again, a Caucasian gene, very common in Caucasian ancestries. And there's another one that's been identified in the African American population, which is associated to some degree with severity of the disease, but they're completely different genes, they're different tissue types, and there's admixture, of course. You know, as people move around, intermarry more and everything, MS is becoming more homogeneous, and it looks more and more like the typical relapsing remitting MS, and that incidence is going up in the African American population. So there's a new study out from the MS Society that has been looking at this again. The old number in the United States was about 400,000 people. That's a very old number, and they just did a recent update on that, a large study looking at several different health databases, including Medicare, Medicaid, the Veterans Administration, several large private insurance companies. And it looks like now the prevalence, i.e. the number of people with MS in the U.S. in general, is closer to 1 million. So it's over twice what we previously thought. It's 900 and something thousand. Now that's an estimate based on health claims and so forth from 2008 to 2010, and that's been extrapolated to 2017, 18. But it's certainly much higher than it was originally thought. And we all knew that, but this now
brings it closer.
brings it closer. It's a much better analysis than we ever had based on questionnaires and things before.
Is because there are differences amongst the race and the genders, is there a difference between the treatments as well as the symptoms?
The symptoms, by and large, are in relapsing remitting MS are the same for all. In the primary progressive MS, there's not that gender difference. So primary progressive MS is about 50-50 men and women, whereas relapsing remitting MS is about 3 to 1, 2.8 to 1 to be exact, but it was previously thought to be only about 2 to 1. And that gap has been widening as well. So each time the numbers are reassessed, the female to male ratio is a little bit higher with each one of these large studies. So it's approaching 3 to 1 now. A lot of that is probably something to do with a hormonal effect, and we don't know which hormone, but we know that MS, you're a OBGYN, as you know, MS tends to be very quiet during pregnancy, unlike other autoimmune
Which
diseases.
is another myth.
Yes.
Most people think that you can't get pregnant while you have MS, or it's going to get worse during the pregnancy, but that's not actually true. It actually depends on, were you quiet before you got pregnant?
Exactly.
And you know, if you were, then chances are you'll stay quiet during the pregnancy. But on the end of the pregnancy, going into the postpartum period is when you may see more relapsing.
So you have to be prepared to do another MRI if you need to, get some steroids if you need to. Depending if you're breastfeeding, you want to get back on your disease-modifying therapy if you're not planning on breastfeeding. But that's a myth, again, that you can't get pregnant in MS or you can't have surgery with MS. These are all old myths. You can live your life pretty much normally, but I would encourage you to be on treatment if you have.
Absolutely. And, you know, as OBGYNs, there's only so much, you know, we are capable of doing. You will still see your neurologist while you are in our care during the pregnancy, and that's really important because we don't want you to relapse during the pregnancy. We don't want you to relapse after the pregnancy either. So that is key to, you know, stay on top of your condition as best as you can. Now, Faye, you talked about some of your triggers. Are there any other triggers besides heat?
Stress.
Stress is a big one.
It's a huge one. For me, it's extreme cold or extreme heat. So again, you have to alter your lifestyle a little bit. So when I go on vacation, I don't stay out in the sun for too long, and if I do, I make sure I have an umbrella over my head because, and if I start feeling like I'm getting sick, which my fingers, because they've already been damaged from the first attack, they start swelling and like getting red. And so I feel, like I'm not myself. So I go into like an AC room and just kind of rest. You have to listen to your body. That's one thing I've learned over the last 11 years with having it. Anytime you feel like you're not yourself, you feel a vertigo coming on, you're off balance, you have to listen to your body. And, now I know, like, I have to make sure that I'm always, like, at an optimum body temperature, or I could start getting a relapse. So
Now, there are different ways to be able to diagnose MS. We talked about one being the MRI and looking for the lesions. Spinal tap is another one. And what are we looking in the spinal tap for?
So you're looking for abnormal proteins, specifically antibodies in the spinal fluid. So the mainstay of the diagnosis is still a combination of your clinical exam, the picture, the way the patient comes in, what symptoms he or she comes in
So you
with.
have to be touched. You have to be
You
interviewed.
certainly do.
Yes.
You cannot diagnose MS
Over the computer.
over the computer. Dr. Google's not going to do it for you. And you can't be diagnosed with MS on the basis of an MRI scan alone.
Alone, exactly.
There has to be an abnormality on your exam, and sometimes that's subtle. Sometimes it takes a neurologist to pick it up. Sometimes it's obvious. If you lose vision in one eye and you go blind, the optometrist may make that referral and so forth. So it doesn't always come to a neurologist first, obviously, but there has to be something in the examination and the presentation that's abnormal, that's consistent with MS, with the demyelination. Then the spinal tap we do, not always. We used to do spinal taps on everyone, then they were sort of out of favor as the MRI.
That's what I was going to say. The
Right.
MRI came into
They
play.
sort of replaced it, but now with the latest diagnostic criteria, the spinal tap's back in. So if you have only one attack and your MRI looks pretty good, you don't see anything active on the MRI, you can do a spinal tap to confirm the diagnosis and get started
Why'd they go
on
back
treatment.
to the spinal taps?
Again, the whole thrust is to get people started on treatment as early as possible. So there's this idea of dissemination in space, which means you have lesions in different parts of the central nervous system, and dissemination in time, which means you have to have more than one attack. So MS, it's multiple, and it's multiple scars, like you say. Sclerosis is a scar, so it'll affect one part of the brain or spinal cord, it'll go away there, and it'll come back somewhere else. In the old days, we waited before we had MRI. There had to be two different attacks, two separate areas of the nervous system involved before we would say it was MS. And we would do a spinal tap looking for these antibodies, oligoclonal bands in the spinal fluid. Then the MRI came on the scene in the early 80s, and we did MRIs on everyone, and that sort of replaced the spinal tap, and then we didn't wait for the second attack. Now we don't wait for
At
the second
all.
attack. We don't wait at all. If you've had one attack and you've got an abnormal MRI, you may or may not need a spinal tap depending on the situation, the presentation.
that's been
But
a
the
huge
key thing is to
difference.
get started on treatment.
Now, we talked about not using the MRI end all be all. So say, for instance, a patient had a clean MRI. Can they also have a clean spinal tap and
Yes.
still have MS?
It's rare, but it can happen, especially the primary progressive form of MS. Because often there might just be a spot in the spinal cord, and that's much harder to image on the MRI.
And if that happens, how often should the patient then be followed up? Because some patients will say, "Oh, I have a clean spinal tap. I have a clean MRI. I'm good to go. I don't need to see my doctor anymore." But that's actually not true.
No, it's not. So there's no consensus on how often to follow people if they have a normal MRI. Most of us who work in MS will do an MRI once a year on patients who are stable, on treatment, and doing well. If you're trying to make a diagnosis of MS in somebody who's not on treatment, the MRI can be very active, and you might be doing it every month or every 3 months in the beginning to make the diagnosis. And then once you've got that and they're started on treatment, then we usually do it less frequently.
Okay.
The spinal tap's usually a one-time thing. Very rarely will you have to repeat that.
Yeah, I will hope not.
You
You
don't
hope
want
not.
You don't want to do it more than once.
Right.
You don't want to do it that time neither.
And
but
it's not always necessary,
Yeah.
so don't be scared of the spinal tap.
exactly.
So-
Now, what are evoked potential tests?
So those are a different way of trying to get it. Those are what are called electrophysiologic tests, like an EMG or nerve conduction study. It's looking at how fast the nerve conducts. Usually it's looking at the optic nerve. That was the most sensitive and specific for MS. We don't do them as much anymore because we have a new technique called optical coherence tomography, or OCT, and often that can give you not exactly the same information, but basically it can substitute for the evoked potential in many cases, and that's totally non-invasive. You just look in the machine and it scans your retina.
Yeah.
Now, from your standpoint, because you are kind of on the forefront with the not only the fundraising but being out with the walks and the bikes, what are you hearing from other individuals that are living with MS? What are their needs? What is the one need that they say, this is what we got to do, and you go out and do it
Well,
for them?
Definitely, it's fundraising, and two, with the new number that has come out of the estimated almost 1 million people living with MS in the United States, we have to work twice as hard now because that number has increased, and that's twice as much research that needs to be accelerated and funded. It's a louder voice with our advocacy efforts. It is also, providing additional programs and services for those living with MS. So everyone has an MS navigator or a program or service that we can provide for them. And again, it goes back to coming out and supporting us and our just general fundraising efforts that way. But we're at the point we have to work twice as hard now with these new numbers and really fund the research. And there isn't going to be one cure for everyone, as we know, because all the symptoms are different. So it's various pathways that we need to take now to find the cure for our.
And we know that vitamin D
Yes.
and sun exposure are actually ways to decrease someone's risk. Is that correct? And that's
Correct.
that's what they're looking at now too in some studies.
Yes, there are. There's multiple studies going on looking at all of those items. And
How about
elements.
diet?
There's no clear-cut diet that is beneficial for MS disease activity. There are lots of diets that people feel better on, but they've never
Correct.
been shown to alter the disease course. The only dietary measure that has been shown to alter the disease is vitamin D. You want to keep your vitamin D level up, at least over 30, preferably closer to 50. If you don't know what it is, just have it checked. It's a simple blood test. Ask your primary care doctor or your neurologist. They'll check it for you. This whole gradient away from the equator is thought to be an effect of vitamin D, because as you move away from the equator, you get less sunlight, and that means less ultraviolet light. It takes ultraviolet light to activate vitamin D in your skin. So if you live in a northern or far southern
Northern,
climate,
like where we were.
Yes.
where we were,
Where we grew up. We don't get a whole lot of sun in Cleveland.
No. So, or in
We're good
Boston.
now,
That's
though.
right, we're good now.
Yeah. So you can replace that. You can take a supplement to replace
Yeah.
that, and that's important to do. The other big risk factor, the modifiable risk factor, is smoking. Smoking cigarettes has been shown not only to increase your risk of developing MS, but it's been shown to make your MS progress faster if you have MS.
And we talk about smoking on this show all the time because it is the root of so many evils and conditions. So this is just one more reason why you need to give up the cigarettes. Now, it's not really talked about, but mental health in MS. We know that anxiety is a big issue.
Yes.
Depression is a big issue. And how do you combat that?
You have to have a team. So you've got to have a coordinated, multidisciplinary team, as we have. At Shepherd Center, we have a huge team, including mental health professionals. Depression is very common in MS, and it's not a reaction necessarily to the disease. It's not because, you'd be depressed if you had MS too. It's actually something biochemical about the disease. So if you look, people who don't have any disability, who have MS have a higher incidence of depression. People who have the same level of disability as someone who is disabled for another reason, say a spinal cord injury or Parkinson's disease or something like that, they have a higher incidence of depression if they have MS. So these studies have been done. It's very clear that there's something about MS that causes depression. So you've got to speak up and tell your provider, because it's treatable. The standard antidepressant medications generally work very well.
And it's nothing to be ashamed of.
Exactly.
And I mean, it's totally understandable. Like, I spoke to my neurologist about it, and he immediately recommended someone for me to talk to. And you know, whenever you feel like you're getting into that depressed mode, and he explained to me, he's like, you're not a depressed person. Like, you never were that kind of person, but the disease is making you feel that way. So we have to treat it. So you just have to, and I advise any patients that are dealing with it, like, speak up, like, don't be ashamed of it. I struggle with anxiety also.
And the fatigue is almost
fatigue,
universal.
the fatigue is, it will get you. I mean, it's so unpredictable. You want to do so much, but your body just won't allow you. So, you know, it's just staying in constant communication with your doctor, talking, being honest. When you go for your visits, just letting them know exactly how you feel. Even if you think it's the weirdest thing,
Or it's
just
nothing.
mention it, because sometimes it may not be MS, but it could also be a symptom of your MS. So.
What about support groups?
Yes, we do offer support groups across the country. And again, you can find that information on our website. And if you are living with MS and you haven't reached out to us yet, please do, because we have an incredible navigator program that can provide resources, references, information, and connect you with the individuals.
Get that information to them again.
Yeah, it's nationalmssociety.org.
Dr. Boko, how can they reach you?
They can email the Shepherd Center, or they can call the main number there. It's 404-350-2020, and they can get to the MS Center. And we're always taking new patients.
Faye, do you offer support and get support for you?
I do. I have a great support team. I have doctors for my optic neuritis, a neurologist. I see a therapist from time to time just to make sure, you know, everything is balanced for me. But I also, whenever I do the charity walks, which I've done the New York Walk, the Challenge Walk, and I've worked for them, the National MS Society before. I think one of the things about connecting with people and them realizing that I have the disease and I'm working for, you know, the organization too, it helps me to like let new patients, especially when they're diagnosed, to just kind of hold their hand and let them know, like, this is what's available. A lot of times people are so scared, and I remember being that person, and so whenever I can, I always try to like reach out. I hand out my numbers sometimes because someone will come up to me and say, you know, my daughter is scared, she's young, can you talk to her? And I have no problems doing that. Like, I'm always, and just to give, you know, recognition to this disease, because again, it's something that's not talked about. People don't really understand it, and so we appreciate just getting the word out. And so I'm always here if anyone wants to talk to me.
Absolutely. Well, I thank you all once again so much for being up here with me, giving the vital information that patients out there need. You know, the theme for my entire show, as you know, is be your own advocate. If you think something is not quite right, if you're not feeling the way that you usually feel, you need to see your doctor. And if your doctor is not taking you seriously, you need to push or maybe find another doctor. But you don't need to settle for anything, because settling doesn't get you anywhere, and sometimes it gets you in a worse off situation. So just make sure that you keep pushing. Make sure that you are reaching out to, you know, your support systems. Make sure that you're reaching out to the national organizations for whatever diagnosis you have. For us today with MS, it's the National MS Society. So there are resources out there. You don't have to do this alone, and just be you.
Yeah.
It's okay.
It is definitely okay.
It's okay. So, you know, until we meet next time, thank you so much. Once again, I am Dr. Tami Prince, the nation's bedside doctor, and you've been tuning in to Health Tips with the nation's bedside doctor on Clark TV Network. See you next time.
So my name is Ellen Mowry. I am an assistant professor of neurology at Johns Hopkins University in Baltimore, Maryland, and I'm a researcher and clinician working with people and for people with multiple sclerosis. So my work focuses on risk and prognostic factors in multiple sclerosis, and I'm specifically interested in factors that can be modified to make a difference for people with the disease. To date, a lot of my work has focused on vitamin D, which we have known for some time is a risk factor for MS. In addition, I'm starting to focus more on other aspects of diet to see how various diets may impact the disease, and also to see how diet and the bacteria in our gut might work together to play a role in MS. And so diet and vitamin D, exercise, these sorts of things are exciting because patients can take some of those issues up on their own. And if we can show that certain diets are very helpful for MS, then I think patients have a lot of control over that. And can make really positive lifestyle changes that will impact their disease in an excellent way. The funding that I received from the National MS Society for a fellowship was really pivotal to ensuring I was able to continue as a researcher. Interestingly, one of the things that I was able to do during the fellowship was a master's degree in clinical research, in which I took a course in clinical trials. And it was during that course that I actually conceived of and wrote the clinical trial studying vitamin D that is now funded by the National MS Society. What I find fulfilling about doing MS research is that when I interact with my patients in the clinic, I can tell them that I'm working every day to try to make their disease go away, or at least to make it better. I'd like to tell people with MS that we're with you. We don't walk in your shoes every day. We don't know from a firsthand experience, for the most part, what you're living with, but we see what you're bringing to us. We're inspired by you, and we're working hard to make a difference to make MS go away.
There was an old woman who lived in a shoe. She had so many children, she didn't know what to do.
Did you have a good day at school?
She gave them some broth without any bread.
There you go.
And kissed them all soundly
Night night.
and put them to bed. Hunger is a story we can end. End it at feedingamerica.org.